All right, so next will be surgical considerations for kidney cancer. So the slides above, that picture shows you how the pathologist bread loaf a specimen. That's how they section it once they get it. You know, if we do our surgery correctly, we stay outside the cancer. Patients sometimes their families are surprised when they ask me after surgery, doctor, what did it look like? I say, I don't know. Because if we do the surgery right, in most cases, we don't see it. We stay outside. And so it's the pathologist who cuts into it, and they literally cut it like a bread loaf, which is why it's called bread loafing. And then what they'll do is sample, you know, the inside. And this is a classic clear cell RCC, this canary yellow color. And you can see this is the outer surface. This is what I saw during surgery. So I'm going to go over considerations that we have when we're evaluating patients for surgery, treatment options. I won't go over the other ones you're going to hear about separately. And I think that might be all we have time for. One of the important things for you all to know, and I think, again, this crowd probably knows, but kidneys don't regenerate. We're born with way more kidney function than we need, but we lose it over time. And then if you add high blood pressure and diabetes, we lose it even faster as we get older. And then if we're cutting off a piece of the kidney, it's not regenerating. If we take out an entire opposite kidney in a healthy patient, that other side will compensate the same way working out your muscles will grow, but it's not really regenerating. The only real organ that regenerates is the liver. So if our jobs would be so much easier if the kidney regenerated, but it doesn't. And so this is a graph from several years ago, but it's a great example of how the purple column is what I want you to look at. And the CKD is chronic kidney disease. So you can see with age, as age goes up, the likelihood of chronic kidney disease, meaning reduced kidney function, goes up. And if you add high blood pressure and diabetes to that, it's even more steep. And so, of course, when we're seeing a patient, this is a key factor for us to look at. What is their kidney function? Number one. Number two, what's their kidney function going to be after whatever treatment I want to recommend? And there's ways that we can try to predict that a little bit. So we want a thorough medical history. When I operate on someone, I'm essentially temporarily inheriting all of their medical conditions. I'm essentially responsible for all their pacemaker, their strokes, their heart attacks, their coronary stents, their diabetes. So all of that, right? Now, I can't do that all myself or rely on consultants, but I still need to make sure everything is managed. All the drugs for all those things have to be addressed beforehand. We have to stop blood thinners. Different blood thinners have different days. Different diabetes drugs have different days and bring on anesthesia complications. If we don't stop it, guess what? Case is canceled and my surgery schedule is booked out 2 months. When am I going to bring that patient back? So these are all things that we have to manage, and we don't really talk about it very much. But you can imagine when you're seeing multiple patients with these multiple medical problems that we see these days, you know, you require an entire team to help you to get through it. And so a lot of times also, if it's a patient that, you know, gets to be a bit complex, thankfully we have a medical team here, an internal medical team, and what they do is help prepare and optimize patients for surgery. So we spend a tremendous amount of time and effort to lower risks wherever we can. I would say 50 to 70% of the energy that we spend is preventative. Well, we can't eliminate risks. And this is something I remind patients before surgery. I'll do everything I can to make it go as safely as I can, but I can't eliminate that risk. And then when a patient shows up with much higher than normal risk, we can only bring it down so much. Okay. So the other considerations is if someone's had prior abdominal surgery, usually not a problem. We can manage it, even with robotic and laparoscopic surgery. But if they've had prior infections in the abdomen within the peritoneal cavity, like a ruptured appendix or a gallbladder surgery that went bad and there was bile leakage, that can be a major problem. And the scar tissue from that sometimes can be prohibitive. We sometimes call that a hostile abdomen, meaning we can't really go in there. And then we have to figure out something else. We talked about the drugs already. You know, we used to give you all this nasty stuff to drink to clean you out. We don't do that anymore. Turns out it didn't really help and it actually hurt. We do want you to shower a couple of times before surgery. So look, the other thing that's critical for me is imaging. There's nothing I can do without imaging. Occasionally, a patient gets very upset when I don't touch them and examine them. But because there's nothing, you know, I just need to make sure you don't have scars in your belly you forgot to tell me about. But basically, I'm completely relying on imaging. And there is no way I would do surgery without a scan right there in front of me, because the last thing I will ever do is take out the wrong organ, the wrong side. Yeah. So I'm not risking that without scans up there. Yeah. And so that's a big thing for us and for me. And we want that connected to the record so that we know that we're in the record. When we open up that scan, it's that patient. When I work with my fellows, every time they're newly rotating on me, I always quiz them. What are the two most important pieces of information on this scan? Name and the date of the scan. Okay. And if you don't get in the routine of checking that one time, you will get burned. And then I actually, in terms of imaging, the other thing is for like partial kidney removal, I do all my own ultrasound. Many of us do. It's a surgical ultrasound that we do. And basically that helps us see inside the kidney and be able to plan out the margins. I'll show you an example if I don't run out of time. We do have to reposition the patient. The kidney, as I'll show you in a minute, is a very deep organ covered by a bunch of other organs. We need gravity to help us. And so for that reason, we have to put patients on their side once they're asleep and then prep the entire area. And we have to do a lot of preventative maneuvers, a lot of padding. There's multiple personnel, anesthesists checking the arms, the shoulders, neck, the head. The circulator and the nurse are checking all the other parts. So here's the kidneys, as I think you guys know probably. But here's the kidney on the right side. It's covered in large part by the liver. You have also the colon, the duodenum. On the left side, we have the spleen, the pancreas, the colon, the small bowel, lots of other critical stuff. And yes, the kidneys are up here, despite what boxers tell you about kidney punches down in the hip. Not really. So the kidneys are way up in the lower part of the rib cage. And so for us if we're going through the front, you can imagine you have to go through all of this depth to get here and also get the liver and everything else out of the way. So there's many different types of surgery we do. We do radical or partial nephrectomy, open or laparoscopic or robotic laparoscopic surgery. And even those we can do transperitoneal or retroperitoneal. What does all that mean? Well, radical means we're taking wide margins around the kidney and the tumor. This means that we're removing the envelope of fat called Gerota's fascia, along with a portion of the ureter. Sometimes it includes the adrenal gland. It does not have to. And sometimes we remove the nearby lymphatic tissue. It does not have to. This is an example of what it looks like. Doctor, what did it look like? Well, it's just a bunch of fatty covered stuff, right? I did that surgery correctly. I don't really see it unless it's bulging out of that. And then once the pathologist cuts into it, then you can see that here's the kidney. And then here's the cancer, and here jutting into that Gerota's fascia. So complete removal of the kidney surrounding fat, part of the ureter, maybe the lymph nodes, maybe the adrenal. We can do this either open. These days we do it if it's very large or complicated, or we do it with robotic and laparoscopic surgery. We still have to make an incision at the end of these cases to get it out intact. It's usually inside a bag when we do that. But that incision only has to be as big as the specimen and not really any bigger. So partial nephrectomy is when we're doing a partial kidney removal, usually for smaller tumors or in cases when there's really severely low kidney function and we're trying to preserve kidney function. For tumors that are less than 4 centimeters, the cancer outcomes are just as good as removing the whole kidney, but with the benefit of preserving more kidney function. And so the decision between the two really depends on a lot of factors that I'm not going to go into, but all of those things that I have written down. The other thing I want to show you is that it's actually fairly complex because not only do we have to worry about where the tumor is, but within the kidney are arteries, veins, the urinary tract collecting system, and they're organized in almost a spiral circular fashion and not like in a nice line where we can, easily, just close things up. And if you're not careful, you can actually kill off a part of the kidney that isn't affected by it. So in terms of open surgery, again, we do this for very large or complex tumors. I'm a big fan of these first two incisions, the reverse L or the midline. Sometimes we do the flank for a complex partial nephrectomy if we're trying to do it through an open incision. I don't like this incision at all, just not very helpful. So this is an example of when we might do an open surgery, like with something like this, huge tumor that's actually invading the liver, and we needed the liver surgeons as well to take out a portion of the liver. Here's a case where we actually did with an open partial nephrectomy, very complex case of a tumor deep in the kidney, adjacent to the urinary tract, which is this bright white part, the renal pelvis. It's splaying it, pushing it out of the way. And it's surrounded by multiple blood vessels that are feeding the normal part of the kidney. I think it was a solitary kidney. I can't remember for sure if it was or not. And so we did that through a flank incision. And so, oh yeah, this is the case. I forgot I had it here. So this shows the kidney after the fat has been removed. This is a vessel loop. It's helping identify the vein. The red one's around the artery. Here is actually part of that urinary tract that's coming out. You don't really see the tumor. You see a bulge of it through the fat here. Most of it is hidden here. So what I've done now is basically done ultrasound, and I can see inside the kidney with the ultrasound, and I've marked out where I want to cut based on where I've seen the tumor inside. Yellow is like, it's really color coded. It's like urine is for yellow is for urine. This is where the urine's collecting inside the renal pelvis. And then basically what we have to do is stop the blood supply. That's why the kidney looks all pale there. And so this way, as I'm cutting into the kidney, it's not bleeding out. Number one, I don't want the patient to bleed out. Number two, I need to see what I'm doing. And if it's bleeding out the whole time, I can't. So we stop the blood supply temporarily. The downside to that is that now the clock is ticking and the kidney can't go without blood supply for, a long period of time. So then we're really having to work. And so what I'm doing with this is that every time I make a cut and go deeper, I'm making sure that I have good margins around the tumor. This is the tumor being pulled out as we're separating it. And then ligating anything that we've cut, like blood vessels, urinary tract, things like that. Sutured back up, closed. And then of course, we reestablish the blood supply. That's why it's starting to look pink now. And then here's what that looked like. You can see the margins were very close in some areas, and that's okay. As long as it's negative, it's okay. You don't have to have a bunch of tissue around it. CT scan 6 years later, no recurrence, well-functioning kidney. Okay, so then there's other ways to do it, like laparoscopic. This was like using chopsticks. We don't really use it as much anymore, but there are places in the world where they don't have robotic systems. They still do it this way. And that's how we first developed minimally invasive surgery. Now, for most of these surgeries, we do robotic laparoscopic surgery. Basically, this is a system where the surgeon sits on this console, the patient's on the bed, and then this, what they call the patient side cart, basically the actual robot itself has got 4 instruments that go in through these small punctures in the abdomen. And what they have is that these instruments have micro-wristed instrumentation. So we now have 6 degrees of motion where we didn't have before that can replicate wrist and finger motion. And so that makes it much easier to do complex surgery like a partial by allowing us to cut things out that are irregularly shaped and in weird locations, and also suturing. And so, yeah. And so this to show you some of the positioning, how we do it. If we go transperitoneal, it means that we're going through the front, and we usually have the patient at a 45 or 60 degree angle on their side. The side we're operating on is up, because once we go in and mobilize the small bowel, the intestines, gravity will help pull them down, and we have exposure to the kidney. If we're going retroperitoneal, that means we're going in that compartment where the kidney lives by itself and avoiding the peritoneal cavity, which is here. And so for this, we have the patient 90 degrees up and down, and then we go in through the back and the side to operate direct and go right to the kidney. We have much more limited space when we go retroperitoneal, and it can be, it's easier for tumors that are closer to the back of the kidney. So there's a variety of factors there that we have to consider. So as we're doing kidney surgery, we want to dissect out the renal artery and the vein. If I'm doing a partial nephrectomy, I actually do ultrasound twice. And then if we're doing a partial, the other thing we have to do is take the fat off the kidney, except keep it on the tumor there, because again, we're trying to avoid getting too close to the tumor wherever we can. And so this is just like a cartoon that shows you how, with the ultrasound, here's the tumor, kidney, and the ultrasound helps us see deep. And, based on what I'm seeing, then I can mark out the margins. But that's just roughly. So what have here in my console, I have a picture-in-picture view. This is what I'm doing. Here's the tumor, here's the kidney. That's the ultrasound. This is the ultrasound probe. In the right hand is a scissors cautery. And here I'm looking at the ultrasound view. So once I know where I want to mark it, then I use the cautery mark, and then I can connect the lines and then cut this out. The other thing we have to deal with in this day and age is a lot of fat around the kidney, especially men. Men, for some reason, tend to accumulate it centrally there around the kidney. If it was just the amount of it, that wouldn't be an issue. The problem is it's highly inflamed and it's stuck to the kidney and it's got blood vessels in it. So we can literally spend over an hour of the surgery just carving through fat. And the problem with it is that it's dense and it mimics kidney and tumor tissue. And so, if you're trying to then, if this is the kidney, here's the tumor, and there's this huge layer of fat, you can imagine it could be difficult to find this in there. So, I've had to develop a strategy to do this, which is essentially to do ultrasound, remove the fat essentially over that portion of it, but maintain it. I still don't see the tumor with my eyes, but I'm using ultrasound. And basically with doing ultrasound again, I can figure out where it is. And then, cut it out and, but it's going to be surrounded with all of that tissue. But it makes it very difficult. These are like the little bulldogs we use to clip the artery in the vein. So open partial nephrectomy used to be, the guy I trained with, Dr. Novick, he used to love huge incisions like this. We don't do that anymore. We used to take out a rib and everything too. And it's rare that we have to do these open these days, as our experience with robotic surgery has really grown. And most of the time, if we're doing it, it's usually more like this. Yeah, and I think we get a good sense, laparoscopic, I've already went over all of this. I'm going to skip over it. The other thing about a partial nephrectomy that matters is it used to be thought that we have to take a wide margin of tissue. The problem with, sort of like this is the kidney cancer. Here's that lot of normal kidney tissue around it. The problem with that is that we're wasting a lot of normal kidney function because not only are we removing it, but that crater that we left has to get sutured. So you're not only losing what's removed, but also what got sutured. What we've learned since is that you can actually get really close. And as long as it's negative, it could be 0.5 millimeter, 1 millimeter. But as long as that's negative, it's okay. And sometimes, so we do what's called an enucleation, which literally means shelling it out. I do this most often for patients with genetic syndromes who have multiple tumors in both kidneys and need multiple operations over years. And then sometimes you do a combination or an enuclear resection where you remove a little bit of the kidney, surrounding normal kidney, and then shell out the tumor. And then there's other strategies for tumors that are hilar, meaning they're touching the blood vessels, where we go in and essentially do some vascular surgery to divide all of the little vessels going into the tumor, and it frees it up, and we can literally ball valve it out of the kidney, and then divide it through the flesh of the kidney to take it off. And so our surgical margins went from looking something like this back in the early 2000s. More often than not, they look like this, but not always. It just does depend on the anatomy. But the point being, we do try to preserve kidneys.